As Kathy mentioned, I'm Shannon. I'm the manager of Brookline Bank here in Arlington. Before I get started with my introductions, I wanted to thank Jody and the rest of the folks at Brightview for the beautiful breakfast they put out for us this morning. They're talented chef over there. And of course, all the folks from American Alarm for hosting us. Thank you all. Okay, so our first speaker today is Dr. Chow. Dr. Chow is an accomplished practitioner who's an OBGYN with the Steward Medical Group in Watertown. Dr. Chow is a clinical instructor in medicine at Tufts University School of Medicine. She's board certified by the American Board of Obstetrics and Gynecology. Dr. Chow earned her medical degree from Tufts University School of Medicine in Boston and completed her residency in OBGYN at Bay State Medical Center in Springfield, Mass. Dr. Chow is pleased to be filling in today for her colleague, Dr. Maureen Cook, who was unexpectedly unable to attend. So we thank you for filling in on the short notice, Dr. Chow.
Okay. Well, first of all, thank you for giving me this opportunity to speak at your breakfast. I've been an OBGYN in practice for more than 20 years, and it is amazing. When I look at the medical advancement and development that we've done, it just never stops amazing me. You know, when I was a resident, we made these big, huge incisions. People stayed 7 days, 10 days. Now we go from this big, huge abdominal incisions to what we, minimal invasive procedures where we make little incisions and we're able to do hysterectomies and all sorts of things. We also have the capacity nowadays to screen for hereditary diseases, cancers like breast or ovarian cancer, such as in the case of Angelina Jolie. So with that in mind, as a result of our evolving knowledge, our recommendation for screening has also changed as well. And I'd like to update some of those changes with all of you. Most of my talk today will be based on the questions that I have received from the computer as well. But one important change that I want to go over is on pap smears. So as you know, pap smears is like the gold standard. When you go to see a GYN, it's almost an equivalent of pap smear. Pelvic exam is almost equivalent, even though it's not quite the same. Pap smear is a test that we do to screen for cervical cancer. So in the past, it used to be that when the woman becomes sexually active, regardless of the age, we do pap smear. We say you have to get your pap smear every year so that you don't come down with cervical cancer. And it's done a tremendous job because in the past 30 years, because of the pap smear, the death rate from pap smears have gone down to more than the decreased rate of death from pap smear have gone down to more than 50%. So this is like the test to do. Now, over the past year or so, in the year 2000, we also developed the technology to detect HPV. And wanted to let you know why HPV is important, okay? It also can be very confusing. HPV is it's actually the most common sexually transmitted infection. It's a virus. It is found to cause most of the cervical cancer. And it is just like a cold virus, anyone who's sexually active, it's estimated that at least 80% or more women has had it at some point in her life. Most of us don't even know that we have it. There are two things that the HPV virus can cause. One is it can cause cervical cancer, like what I was just saying, and the other is that it can cause genital warts. But most of us, even if we have the HPV infection, we don't have an abnormal pap and we don't have genital warts. The reason is because HPV being a virus, just like the cold virus, when we catch a cold, our body builds up antibodies, and it's because our immunity will eradicate the infection. And so we could have it transiently, and it's gone. Just like the cold virus, it also has different strands too. Okay, so what we found is that for women who are 21 or younger, it's very, very common for them to have HPV infection, or actually even into like the late 20s, up to 30s. And that women who are young, they pretty much will eradicate the virus. 21 or younger, usually they'll clear it in 1 to 2 years. So because of this change, the guidelines for the pap smear screening also has changed. And then also, for women who are 30 or over, there's a more tendency for the infection to persist. So as a result of this, the American College of OBGYN changed the guideline in terms of screening pap smear. It's no longer true that once you become sexually active that you have to have the pap done, regardless of the age. You don't need a pap smear till you're 21. And for females between the age 21 to 29, it's recommended that we do the pap smear every 3 years. Because the way the cervical cancer develops is that it usually is very slow. It develops over many years. And the pap has the ability not only to pick up the cancer, the beauty of the pap is that it can also pick up precancerous changes. So you could have abnormal cells, and you may not develop cancer until like 20 or 30 years later. Not like ovarian cancer where we don't have a good test, and you can go from stage 1 to stage 3 pretty fast. And so for the pap smear, because for cervical cancer, because it develops so slowly, it's changed that you only need to have a pap every 3 years if we don't only do the pap for women aged 21 to 29. And then for someone who's between 30 and 65, the preferred testing would be to do the pap, which is screening for the cells, and also to do the HPV, okay? So if both your pap and HPV are negative, then you're good for 5 years. You only need the pap every 5 years. So there's a dramatic change from screening every year to every 3 to 5 years, pap smears. Now, that's not to say that you should skip your GYN annual, because you still have to be examined for other things too. And then if you're over 65, if you've had normal pap smear for the past 10 years, then you actually can stop having a pap. And then for someone who's had a hysterectomy, if you had a hysterectomy done, let's say for fibroids or for other benign reason, like irregular bleeding, then you can, if the cervix has been removed, then you don't need pap smear at all. Okay, so there's been a big change. Now, in 2006, the HPV vaccine also became available. So like I said, the HPV virus basically has over 100 subtype of strains, and the one that I tend to use a lot is the Gardasil, and it's recommended for women between age 9 to 26. And so the Gardasil it protects you against 4 strains, and 2 of the strains are responsible for 70% of cervical cancer, and then the other 2 are responsible for 90% of genital warts. So when you get the vaccine, you have very good protection. It's not complete protection, but very good protection. The more exciting part is that there's actually a newer vaccine that just came out the end of December last year. It's called Gardasil 9. And the Gardasil 9 gives you even more protection. There's 9 strain that is giving you immunity, preventing. And it actually has the potential of preventing 90% of cervical, vaginal, and vulvar cancer. So you could see how just over a matter of a few years that the technology and the development has changed so much. Okay.
Can I ask you a question?
Yeah.
If someone has had the Gardasil, my daughter, who's now 17, 18, she's had the Gardasil, is it recommended that she now get the Gardasil 9?
That is a very good question. I would not, because I think really the biggest risk factor for cervical cancer is not having a pap. So if you had not had a pap smear for years, that's really the biggest risk. So as long as she follows up with her routine screening, I don't think it's worth it to get that little additional protection.
Thank you.
Yeah. Any other questions?
Why, is it okay to stop the PAP at 65?
Because if your pap smears, they've done studies, if your pap smear has been, all right, so, okay, let me step back. HPV is a STD, right? So if you screen negative for the HPV virus and you've had normal paps, by the time you're that age, it's unlikely, although it's really different now, that you can have a different partner.
So it's
And
just based on that?
It's based on that, and it's based on the fact that you've had normal pap
Okay.
in the past. Yeah.
And the same partner?
Yes, assuming it's the same partner. Yeah, so for instance, like for me, I just actually, I had operated on a woman who was, has cervical, early cervical cancer a year ago. And the story with her is that this is a 70-year-old woman, and she, had not seen her gynecologist since she had her last baby, which a lot of the times people do. And so even though the recommendation is not to do a PAP, or that you can stop doing a PAP, but what's her risk factor? She's got the biggest risk factor. She hadn't seen a gynecologist, and she hadn't had a PAP for years. So I did the PAP, and she had very early stage cervical cancer. So, these are just general guidelines, and obviously it's up to the physician or the provider to individualize it. It's in medicine, it's really important that you take each individual, and there's general guidelines, but you need to be able to adapt to a different situation. Same thing for STD screening. It is pretty standard that we screen. The CDC recommends that we screen young women when they come for GYN exam for gonorrhea and chlamydia, because the highest incidence is in the age group 26 and under. So when they come for their routine exam, that we should be screening. But if you have a woman who's, baby boomers who, divorce and just start the dating scene, well, you should screen for it. As a matter of fact, in Florida, I understand, there's pretty high rates of STD. Yeah. So be careful when you go to Florida.
That's so funny.
Yeah.
So boys are vaccinated against this because?
Because it's STD, so why should it just be females?
Right, okay.
Yeah, I think that they started off recommending to the girls, and there was a big taboo too, because the whole idea is to try to get the patient vaccinated before he or she becomes sexually active. Yeah, so it was really difficult in terms of figure out how to present it to the parents. But I think that we've done it long enough now that the pediatricians are very comfortable at
What are the risks for
recommending it.
the boys? Like
It's-
what type of cancer would, is it for the
Well,
girls
it's really more for the girls. It is associated with penile cancer, which is really rare, but the boys can also get genital warts. Yeah, but it's more for the females.
Okay.
Yeah, okay. All right, so next, what I like to do is go over menopause. I passed out the questions. I hope everybody has a handout. Maybe you can share, okay? All right, so I'm just gonna read off the question, and then maybe I'll get some brave soul to volunteer to answer. Menopause is defined as 2 or more irregular periods after age 40, the start of hot flashes, no menstrual period for 12 consecutive months, and increase in mood swings.
C.
All the above.
All the
C.
It is definitely.
It's gonna be all the
It's C.
Yeah.
No menstrual period for 12 consecutive months.
So I'm not menopausal?
You can be
What the heck is wrong
perimenopausal.
with me?
You can be perimenopausal.
What did you
Exactly.
You're
Right, you're
perimenopausal.
Very
perimenopausal.
menopausal, all right,
Yeah.
fine, I'll.
Yeah,
It's
yeah.
not.
So, and it could last for a while.
Don't rush
Yes.
it. Don't rush
It
it.
has lasted for a while.
Yeah, so let's just go over the second question, and then I could talk a little bit about menopause and perimenopause. Okay, the average age of menopause is 51, 60, 55, 49.
51.
You got all the right answers.
51 is right.
51, yes. Yeah.
Yeah.
Yeah. So there is the average age is 51, and most women will start having, symptoms around late 40s. So about 95% of women, they will go through menopause between 45 and 55. That being said, you can have what we call perimenopausal symptoms up to 10 years before you actually go through menopause. So the definition of menopause is that you have to not have periods for 12 consecutive months. If you stop having your period for a year and then you started having some bleeding, then you must go see your doctor, because then there may be something else going on. Whereas if you skip your period for a few months and then gets it back, then you're still going through the perimenopausal phase, okay? And then also, how early you go through menopause, it has nothing to do when you start having your period. It can run in the family, so if your mom went through menopause early, then you can go through menopause early and vice versa. Okay, the most characteristic symptoms of menopause is hot flashes. It varies from woman to woman, mood swings, vaginal dryness, and painful intercourse. Yes, that's right, yeah. All of this can happen, but then you also can have some women, very few, lucky women who they just stop and they don't have any symptoms at all. Yeah, they make us jealous. Menopause increases health risks like heart disease, sexually transmitted diseases, osteoporosis, A and C.
A and C.
Yeah, that's right. Yeah. When you go through, what happens when you go through menopause is that, so in order to have a period, you have to have functioning ovaries. The ovaries has to be making estrogen, and then at the time of ovulation, the ovaries make progesterone. If you don't conceive, then the lining of the uterus gets shed, and then the whole cycle starts again. When you have a hysterectomy, it doesn't mean that you're going to go through menopause, because if you have your ovaries intact, then your body is still making estrogen. It's just that the estrogen doesn't have an organ to affect, because you've removed the uterus, so you won't have your period, but you're not going to go through menopause any earlier than you normally would. If you had your ovaries removed, then yes, you would go through menopause right away. And as a matter of fact, those are what we call surgical menopause, and because the changes is that you don't get to go through your perimenopausal symptoms, you don't get to go through menopause slowly. There's an abrupt cessation of the production of estrogen, and most women tend to have intense hot flashes and become more symptomatic if you had like surgical menopause. So if you have to have hysterectomy because of fibroids, we don't take out the ovaries just because of that. At least nowadays we don't. It used to be that the thinking was that if you're 45 or over, that the ovaries are not going to be functioning that much longer anyways, that we would take out the ovaries to decrease the risk of ovarian cancer. And the risk of ovarian cancer is like 1 in 70 in the general population, thinking that you just have a few years left for the functioning ovaries. But it's really not so healthy for you. And there is some cardiovascular protection for women who are younger, in the late 40s or early 50s, with the estrogen. And that has actually been shown by the Women's Health Initiative, which is a big, huge study that was started in 1991. It was a 15-year-long studies of postmenopausal women, healthy, and the effect of hormonal replacement on women's health. And the study that just had the estrogen alone, and also the study that involved women 50 to 59, when they're on estrogen, there seems to be cardiovascular protection. Whereas if the women were started in the 60s, it actually works against you. So anyways, nowadays, unless there's something wrong with the ovaries, we typically would have a discussion with the woman who's going to go for surgery and see and talk about the risks and benefits of keeping the ovaries in versus removing the ovaries. There's also a very new trend too, and that is the dreaded ovarian cancer. It was thought that it came from the ovaries, but now there's some data that shows that maybe up to 70% of ovarian cancer actually starts off from the fallopian tubes. So for people who are going through perimenopausal women, or women who's done with childbearing, go through a hysterectomy or any other benign GYN surgeries, one of the options that you can talk to your doctor about is, can I have my tubes removed? Because that can decrease the risk of ovarian cancer. So that's another new development. Okay, all right. So let's go on to the next question. Women who are going through menopause should take hormone therapy, estrogen therapy, bioidentical hormone therapy. It depends on the woman's symptoms and medical history. Yeah, absolutely. Right.
Yeah.
Yeah, so when we talk about hormone therapy, we're talking about either estrogen alone or a combination of estrogen and progesterone. If you've had a hysterectomy, then you don't need to be on combination. You just need to be on the estrogen, because usually it's the estrogen, the withdrawal or the fluctuation in the estrogen level that gives you all the symptoms of menopause. Hot flashes, night sweats, vaginal dryness, atrophy, urinary frequency, mood swings. But for someone who still has an intact uterus, you would need to be put on combination, estrogen and progesterone, and the reason is because unopposed estrogen, over the long run, can cause uterine cancer, because estrogen stimulates the lining of the uterus, so it can cause uterine cancer. In that case, we just give patients a combination. So, like I said, there was a big study, the Women's Health Initiative. In the 1980s and 1990s, it was, when I first started out practicing, it was routine, and actually it was the standard to put perimenopausal, postmenopausal women on estrogen or hormonal therapy. And the thinking back then was that we knew that women who are in the reproductive years, that their risk of having heart attack is much lower than men. So women tend to have heart attacks when they're older, when they're through menopause. So we thought that the estrogen would give us cardiovascular protection. The estrogen also will give you protection from osteoporosis because osteoporosis is dependent on estrogen. And so not only are we treating the woman for all her menopausal symptoms, we're also having the medical benefits. And it was practiced until the Women's Health Initiative came out. And that was a huge study. It involved over 16,000 patients. And what that showed us was actually when you're on hormonal replacement therapy, there's a high risk of breast cancer, high risk of stroke, high risk of cardiovascular events. And so the management and the treatment of menopause has shifted very differently. So nowadays, the only time that we recommend or that we put a woman on hormonal replacement is when the woman is symptomatic. Because once again, still, estrogen is the best treatment, most effective treatment for the menopausal symptoms. And the increased risk for breast cancer is not until you've been on it for 5 years or more. So we try to manage that, and most of the symptoms are more intense when you first started going through menopause, and it tends to subside. So we try to manage that period with as low of a dose of hormonal replacement as possible. Now, obviously, there's also other ways too. We have other medication non-hormonal medication that we could put the woman on to control the symptoms. But in general, estrogen is like the most effective. And then in terms of these other identical estrogen, it's mostly derived from soy or yam. It's more natural. However, in order for it to be bioidentical, meaning that it's the same chemical structure molecule as what we normally produce in our body, it has to be commercialized. It has to be we have to tweak it so that it's equivalent to what our body produce. And so there really isn't any strong or good data to support that the bioidentical hormones are better or less risky than being on hormonal replacement. There's just not much data. And in terms of other herbal or other supplements, you can try it. There's like black cohosh, there's evening primrose oil, there's a whole bunch. You can try it, and it works sometimes for some women, but the data has not consistently shown that it's that effective compared to your conventional standard hormonal replacement. Okay? All right.
Separate question.
Yeah.
What's the risk to taking primrose or black cohosh?
Well, I think that it's probably fine if you take it not mega doses. The black cohosh can be liver toxic, and we don't really know of, because there's not that much studies on it. We really don't know what the potential. Yeah.
I just wondered anecdotally what you see in your patients in terms of any success they have with these alternatives.
I think that usually if your symptoms are not that severe, the vitamin E never works. Black cohosh, I've seen it, and evening primrose oil is another very popular one. Yeah. Yeah. But, yeah.
Oh, I was just gonna ask a question.
Go ahead.
I was just wondering about the estrogen, like how long is too long to be on it? Like, if you're on it for 5 years, like after 5 years, the risk increases a lot. How long can someone be on estrogen or? Like,
Yeah,
like,
yes.
is there a time that's too long? Like someone should.
Well, I mean, there is an increased risk of breast cancer after 5 years, okay, it's about 30%, okay? And the risk of breast, I mean, in the United States, 1 in 8 women will develop breast cancer, okay? And so usually we try to have the woman come off it before that 5 years. And most of the time, we're able to do it because just because the most intense time is the first year or two. And plus there are also other options too. There's blood pressure medication like called clonidine that sometimes we use. There's Zoloft and Paxil that we use. It's more commonly used for anxiety and depression, but it also works quite well in controlling the menopausal symptoms. Yeah. Okay. All right. The most accurate test to determine if a woman is perimenopausal is follicular stimulating hormone, complete blood count, urinalysis, or none of the above.
None of the above.
FSH?
Who said none of the above? You again.
That's because I'm so old.
It's none of the above. The trick is, it's actually a trick question. It's really not fair. Because it's perimenopausal. So once you go through menopause, once you not have your period for 12 months, your FSH is going to be elevated. But what happens when you're perimenopausal, when you get to that point, is that your body is like this, your level. And so it's going to be up and down. So depending on when you get the blood test, it could be up here or it could be down here. So it's not predictive. And that's why sometimes my patient would ask me to do a blood test. I mean, I could do it, but when you're going through menopause, it's really starting to go through menopause or in the transitional period. It's really not helpful because it doesn't tell me when you're going to finish doing what you're doing. And then by the time you really actually don't have your period for 12 months, I don't need a blood test to figure out that you've gone through menopause. Sometimes we do check blood tests like thyroid, because if your thyroid is underactive, it can cause you to have irregular period. But, and I see FSH, check your FSH in all kinds of magazines. It's not, it's really not predictive at all. Yeah. So, but like in the case, let's say if a woman has had hysterectomy, because one of the most common symptoms that you have is you go start skipping period. Most of the time it becomes very irregular. Most people will skip, but sometimes you can also have more frequent periods, and that's when if you have a fibroid, that's when it tends to act up too because of all these hormonal changes. So if you had a woman who had a hysterectomy but still had her ovaries intact and can't really tell and not have any symptoms, and she's like 52 and doesn't have any symptoms, then in that case it would be worth doing it because I can't tell because she doesn't have her period and she doesn't have any symptoms, and even though most women would have some symptoms, if you don't have any symptoms, I can't tell. So I might do an FSH just to see if she's gone through menopause. And in that case, it's helpful. Okay. Which of the following are proven alternative therapy for menopause symptoms? Black cohosh, plant estrogens, herbal, none of the above. None of the above. Like I said, I mean, they can help, but it's not proven. There's no studies that has supported the efficacy in terms of treating menopausal symptoms. During perimenopause, some doctors may prescribe which treatment? Hormone therapy, birth control pills, benzodiazepines, A or B?
ARB.
Yeah, A or B, yeah. Which is not a usual symptoms of menopause? Night sweats, back pain, headaches, anxiety.
Back pain.
Yes, that's right. Yeah, although sometimes, once in a while, some women will feel more achy when they go through menopause, but it's not typical. Most of the symptoms would be, first, the most common would be the irregular periods, and then the hot flashes, or the night sweats, and then the mood swings. Okay. If menopause occurs in a woman younger than what years, it is considered to be premature.
45, 30,
30.
40, yeah, 40. Yeah, so, certain conditions, like I said, in the United States, the average age of menopause is 51, but if, someone who had cancer, had like radiation or chemotherapy, then they could go through premature ovarian failure or menopause. Or if certain genetic disorder can also cause you to go through menopause early too. Okay, which factors can affect the timing of menopause? Surgical removal of ovaries, chemotherapy and radiation, medication, A and B. Yep. Hot flashes can last from a few minutes to a few hours. True or false?
True.
True.
You got it wrong. Hot flashes. Hot flashes can last up to a few minutes, but not few hours. Few hours is a long time. Yeah. So, but even though it feels like it's hours when you have it.
Yeah, really.
Yeah. So, if if you're hot for a few hours, then there's probably something else going on. Yeah. And go ahead.
Well, I just wonder, how many hot flashes in a day or a night is average and normal?
There's no average, and there's no normal, because hot flashes, I would say, most people, it seems to me that for my patient population, that they complain more of night sweats, flipping those covers, cover again. I don't know if it's because it's more common at night or it's just more noticeable, because during the daytime you tend to be working. And the way we approach it is really how much it bothers you and how it's interrupting your daily routine. Some women can have hot flashes or night sweats so bad that they can't get a good night's sleep, okay? Or they could be at a meeting and all of a sudden they have the hot flash and flush, and especially in a room full of guys, and they're looking at you. So that can be very embarrassing. So we to really.
Did you hear? I announced it yesterday in a meeting. Yes.
So we really treat based on symptoms. Yeah.
Can I make a comment? I noticed that when I was perimenopausal and then into menopause, that also certain foods would trigger the hot flashes. So spicy foods, caffeine, alcohol. And so I think it's important for people to pay attention to what your diet looks like and the amount of stress that you're under, because that can also, I think, be a factor. Am I correct?
Absolutely, you name it all. The caffeine, the alcohol, the stress, hot weather. So as a matter of fact, when I try to wean my patient off or go down to a lower dose of a hormonal replacement, I do it in the fall and winter, because then you have the cool weather. But lifestyle is so important, absolutely. And then exercise seems to help too. Yeah. Okay. About 15 to 28% of postmenopausal women can still bear children.
I said false.
False.
There's no juice left.
Because menopause, what happens in menopause? Your ovaries stop working, right? So it's not going to produce any more eggs. If you truly have gone through menopause now, by definition, not having had your period for 12 months, then you don't have to worry about getting pregnant. Now, if you're perimenopausal, you still, the hormones are like this, and you could still ovulate and you could still conceive, although the chances of that happening is still very low because the eggs we're born with it, and it just declines with age, and so your chances, how fertile you are, even if you're healthy, just decline with age. So it is unlikely that you're going to conceive, but not impossible. So you still need to use some kind of protection, and that's why sometimes we'll put a woman on the birth control pill perimenopausally, because it'll give her the protection, contraception, and it will also treat the symptoms as well, okay? But after menopause, you don't have to worry about pregnancy, but you do need to worry about STDs, okay? And there's only one way to prevent STDs is to safe sex, use condoms, or make sure that your partner be tested. That's the only way. Okay. As a result of menopause, which of the following is least likely to occur? Decreased estrogen level, vaginal atrophy, osteoporosis, osteoarthritis.
Osteoarthritis.
Yeah, that's completely unrelated. Everything, all this, the symptoms listed above is due to the decreased level of estrogen. Male menopause is sometimes described as a condition referred to as low testosterone or low T. True or false?
Sure.
Yeah, they go through menopause too. Yeah, not as intense as we do though.
They just buy sports cars.
Yeah, that's true. I know, we got to figure out something that we should do, right? Yeah. Menopause increases a woman's risk for depression. True or false?
True.
Yes. It all goes with the emotional changes. You can have increased anxiety, fear, depression. Yeah. Okay. Any questions?
I actually have a question. I know one of the questions that I fed as a result of the wonderful questions that you all completed here to submit to Dr. Cook was someone had asked about having had a hysterectomy. Again, like how would she know when she was actually going through menopause? So I assume that she had her ovaries taken out too, but again, for her measure or her marker, how would she figure that out when she was starting to go, like perimenopausal?
All right. So if you had a hysterectomy, okay, if you had your ovaries taken out, the time that you have the surgery, you are put into menopause because no longer do you have your ovaries. Okay, so your body's not producing any estrogen, and that's why most women who's had a complete, meaning the uterus and the ovaries, that most of them will have hot flashes. Okay. Now, if you had the hysterectomy, just the removal of the uterus, and you have your ovaries left, then it's harder. Most women, when they go through menopause, will have some symptoms of hot flashes or night sweat. But for the few who don't, then the only way to test it is to test the FSH. Yeah. Okay.
I have a question about a blood test versus saliva test for hormonal changes. Do you have experience using the saliva test?
I have heard of it. I think they're pretty, equivalent.
Oh.
Yeah. Yeah, we can do a lot of saliva tests now in place of the blood test.
Question regarding mammograms and when you have dense breast tissue, and you've been told you have dense breast tissue, what's your opinion on getting a breast MRI versus the mammogram? Do you do both? Do you think it depends? I'd love your opinion on that.
Okay, so, like I said, 1 in 8 women will develop breast cancer in her lifetime. And that only 10% of breast cancer is hereditary. So your biggest risk factor is getting older and being a woman, okay? And since, you know, the recommendation to do routine mammograms, the breast cancer, how we treat it and the detection has changed a lot. Most women nowadays with breast cancer, we're detecting it early stage. That being said, if you have, and with dense breast, it is, because mammogram is black and white, and it is much harder for the doctor, the radiologist to read it. And so it can be, you can, well, the false negative rate, meaning that not having a normal mammogram and still have some kind of cancer or disease underlying, it's about 15%, okay? So it can be harder, and the false negative rate can be higher. And MRIs has been shown to pick up cancer in some cases where the mammogram have missed it. There's also the 3D mammogram nowadays that's supposed to be better, and I think that there's going to be more development in that, and I think that that's probably where we're heading towards. It's still kind of expensive now, but I think that the MRI is very, very expensive, and it's really not indicated for someone who just has dense breast tissue. But you know, if there's any question about, let's say if your mammogram is very dense and they keep on saying you have to come back and repeat in 6 months, then there can be a role in MRI or the 3D mammography. The risk for breast cancer too is that we know that women who are obese at a high risk, if you exercise on a regular basis, it also would decrease the risk. And and the other thing is that vitamin D, and I'm a big fan of vitamin D. There's so much that's being studied in vitamin D. People who's had breast cancer, if their vitamin D level is low, then they are at high risk of getting recurrence of breast cancer. And for women who are pregnant, if their vitamin D level is low, they're at high risk for developing diabetes. So I think that we're just beginning to touch on the surface of vitamin D. Not only is it, you know, good for our bones, it has a lot of different roles in our body. And I think that we're just on the surface of it. And actually there's vitamin D deficiency is very high, especially up here, because the only way most of the time to make vitamin D is from sunlight, okay? So what do the dermatologists tell us to do when we go in the sun? Sunscreen, right? And most of the time here, we had a rough winter. I mean, like I barely went outside, there's no sun, right? So, and when I check my patient's vitamin D level, I mean, like a lot of them are very low. And ideally, even though like the minimal level is supposed to be like 30 or 35, that level is only based on the amount that's required to prevent osteoporosis. So there's not, we don't know what's the ideal level. And I think that its price should be more, at least 40 or over. And I would say to everybody in this room, just take a vitamin D supplement, 2,000 international units a day. And you know, it's not gonna, it's only gonna help. Okay? Yeah.
Would you talk a little bit about the changes in the guidelines about mammograms, in your opinion, about when women should have them and how often?
Yeah, okay. All right, so the American College of OBGYN, which most of us go by, is, recommends starting mammogram at age 40, and that you have mammogram every 1 to 2 years until 50, and then from 50 on every year. That's a different recommendation from the US task force, which recommends that you you don't start mammogram till age 50, and that you get your mammogram every 2 years, okay? The reason being different is that they felt that, well, first of all, breast cancer nowadays, because we detect it so early, that most people don't die of breast cancer. It's more, turns into a condition that you live with, okay? And also, when you detect it so early, the treatment is not as horrible. You may only have to have a lumpectomy and radiation. You don't have to go through chemo, which is it can be very hard on your body. And the task force also does not encourage breast exam, which I don't agree with. And the reason why they say that is because with all this excessive screening, what happens is that if we end up seeing a lot of benign findings, that the women end up having biopsy and it turns out to be benign. And so a lot more procedures and a lot more anxiety that's caused because of that. And that it really doesn't affect the mortality rate. But I think that not only do you need to look at the mortality rate, you also need to look at what we call the morbidity rate, meaning that if you caught a breast cancer in its early stage, like I said, you may not have to have chemo. If you catch it later, even though the woman will live just as long, she's probably going to have to go through chemo. And so that can have an effect on your lifestyle. So the American College of OBGYN still pretty much has the same recommendation. And I can tell you that for me, self-breast exam, I don't think there's any risk to it. Yes, it could create unnecessary anxiety, but the woman can, she can go to her doctor, and then the doctor can make the final decision. I can tell you that I've had women who had normal mammograms and had breast cancer 6 months later that they found a lump in the breast. It's not that often, it's only a handful, but it happens. So I think that you should still continue to do self-breast exam.
And will insurance carriers change their coverage based on the US Task Force recommendations?
They have not, because the American College of OBGYN is really the standard for OBGYN. Yeah.
Can you go back a little bit when you were talking about having ovaries removed and the effect of menopause? What if somebody has only one ovary removed?
Then you don't go through menopause because your remaining ovary will just work harder.
And does it have an effect when you actually do go into menopause?
You go through menopause just like if you had 2 ovaries.
Okay.
Yeah. Same reason sometimes for younger women, they have benign or large ovarian mass. We just remove one and they still can conceive without any problems. Yeah.
I have a question. On the estrogen, I'm 59, I've never had any estrogen. Is that a replacement? Is that bad for other things like,
No.
osteoporosis, like you said that it helps with?
Right. It helps with osteoporosis. So most people, we don't really, unless you have risk factors, osteoporosis is a very slow progressing disorder, and most people really don't develop osteoporosis until they're in the 60s. So the screening for a healthy woman, when to start for a bone density is when you're 65. It is, but in the meantime, we know that our bones are shrinking, okay? So it's important that you do the exercise. You take, have enough calcium, the vitamin D, and really the weight-bearing exercise is what's really important, okay? There's also medication that we have nowadays to treat specifically osteoporosis. Back in the 80s, there weren't. So the hormonal replacement therapy was the treatment as well.
Thank you.
You're welcome.
It's almost 9 o'clock.
Okay,
I
well,
can't
you'll-
believe it. So, could you just introduce Anna? I think we could have you stay here until probably noon.
Yeah. Thank you.
The next speaker we have today is Anna Kashishian. Anna is a certified nurse midwife who will be seeing patients at Steward Medical Group Arlington. She holds a Master of Science in Midwifery from the Philadelphia University in Philadelphia, Pennsylvania. She's also a graduate of the Bay State Medical Center Midwifery Education Program located in Springfield, Mass. Anna's here today with Dr. Chow. Did you want to come up and say a few words, Anna?
And Dr. Chow, you didn't have to sit down. I didn't mean to like give you the hook.
Good morning, and thank you for having me here today. Some of you probably wonder why a midwife is present at a menopausal talk, but a reason for it. Midwives in the United States are trained very differently than they're trained in Europe and probably in Canada and other parts of the world. I'm a certified nurse midwife, which means that I've been trained in 2 disciplines, nursing and midwifery. And the United States midwives believe that we provide care to women for a lifetime, not just while they're pregnant. So we see them from when they get first period to after their menopause. We frequently we work hand by hand with the doctors at Steward, and we complement each other. We also adhere to all of the American College of OBGYN's recommendations and guidelines. So it's not like we do our own thing and the doctors do their thing. We see women for problem visits, we see them for annual visits, we see them for hormonal replacement issues, we see them for abnormal bleeding. We do initial workup frequently, and then they follow up with the doctor and discuss what the plan of care will be. So if you ever call the office or one of your friends calls the office and the only option they have is to see a midwife, they're safe to be seen by a midwife. So thank you very much. Great.